Hello, everyone. So today I have invited Zeina Al-Mahayri on our YouTube channel. So thank you so much for accepting our request to coming off. Our today's session topic is why pharmacogenomics is still underused despite 20 plus years of experiences. So before we start, I would like to introduce Zeina Al-Mahayri. And please, you can tell us about yourself before we start.
Yeah, sure. Thank you. Thank you, Dr. Adnan. So it's my pleasure to be here with you today. And actually, I am Zeina Al-Mahayri. I am a graduate of pharmacy a long time ago. And after pharmacy, I did my master's, which was focusing on genetics, and then my PhD, which was about pharmacogenomics, in which I blend together my passion in both the fields of pharmacology and the field of genomics and genetics. So I have got my PhD from the UAE University, and I've worked there for a couple of years also as a postdoc researcher. And then currently I'm working in Abu Dhabi University as an assistant professor of genetics in the biomedical sciences department. So my passion of pharmacogenomics have started since I have been working in this field like more than 10 years right now, since I started my PhD research, and I published a couple of, or more than a couple, tens of papers in pharmacogenomics related more to pharmacogenomics in underrepresented populations, including the Arab populations, South Asians, and also pharmacogenomics in the field of, or in special cases like breast cancer and acute lymphoblastic leukemia in children, and also in cardiovascular diseases, and some work also in psychiatry. So my main mission in this maybe research or in my career is to spread the word about pharmacogenomics and also to increase the awareness and education in this field, especially in the current era of genomics, which we are specifically in the developing countries. We have multiple challenges. And I would like to share also some material to introduce the audience to the field in a better scientific way.
Yeah, sure. Thank you so much for your amazing introduction. So we can start by sharing your screen. You can start.
Okay.
Yeah.
Okay. So can you see my screen now?
Yes, yes, it's visible.
Yeah, it's visible, and it's the presentation, right?
Yes, 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 the presentation.
Yeah, okay. So my talk today will be trying to address the question why pharmacogenomics is still understood, or sorry, still underused. So to start with this, let's get a very quick introduction about pharmacogenomics. As you can see here on my screen, it is colored word, pharmaco and genomics, two different colors, because it's the blend of two sciences of pharmacology, the science of drugs, their effect on the body, and the body effect on the drugs, and genomics, which is the study of genes and their functions and their interactions together to get the final effect of the functional proteins. So the goal of pharmacogenomics is understanding how individual genetic makeup can affect response to medications. And by this, we can imagine that if we understand how our genetic makeup can affect the medication, we can then personalize treatment and get more effective treatment strategies. So these are the main goals of understanding genetic variants that affect drug response. Actually, the current practice or the conventional practice that we have been taught in pharmacy that for patients with similar diagnoses and similar maybe clinical features will get the same medication. But the end result is that not all of the patients will get the benefit and will avoid the toxicity of the drug, because there are some groups who won't take the benefit and will get only the toxicity. And in other cases, they will not benefit and they will not hopefully won't get the toxicity at least. So all the scenarios are possible, and this is as long as we are giving one size fits all for depending mainly on the disease rather than the patient. So as pharmacists, we know that drug response is a combination of different factors, or it is a result of different factors. It's affected by our lifestyles, it's affected by our disease characteristics, it's affected by other diseases that we are suffering from beside the main indication for the medication. Beside the environment, it has its effect, the food we are eat, our age, our weight, our BMI. Beside all of this, genetics. Our genes are responsible of making proteins that are used to metabolize the medication, to respond to the medication, and to transport the medication. Hence, when we move from one size fits all into applying a pharmacogenetic test, we can make better choices of therapy. So each patient hopefully will benefit from their individualized treatment. So why do you think, or let's dig deeper into the function or the way that pharmacogenomics work. Pharmacogenomics, as I've mentioned earlier, is the melt between genes and pharmacology. Genes are responsible for making proteins, and proteins includes receptors, targets, ion channels, and enzymes that are involved in the metabolism of the drug, or maybe some channels that are responsible for excretion of the drug. So all these, what we know as pharmacokinetic pathways and pharmacodynamic pathways, are all controlled by specific proteins, and these proteins are encoded in our genes. So any changes in these genes will affect the proteins, so will affect one of these pathways. So let's take an example, a very common example, codeine. Codeine is a prodrug, is given as a prodrug, but it needs to be activated into its more potent analgesic metabolite, which is morphine. And this metabolism is mainly dependent on CYP2D6. But for those who have no function or no CYP2D6, will not get this metabolism happening, so they will not get morphine, then they will not get the benefit of the medication in analgesia. On the other side of the spectrum, we'll find some people who have an increased function of at this gene. So they have multiple copies of the same gene. So they have multiple copies of the same enzyme active in their bodies. So that more codeine is converted faster to more morphine, and then they are vulnerable, or they are very at risk, at high risk of toxicity. So we have all the options in between not getting any benefit or getting even toxicity, and this is only because of the presence of this gene or absence of it, or getting any variant that increases or decreases its activity. Another example to make us more understand the effect of or how pharmacogenomics work is the thiopurines, including azathioprine and 6-mercaptopurine. These are medications used for very crucial indications, immunosuppressants, and for leukemia patients, for acute leukemias and as anti-cancer therapies. So these medications are actually, they are active, but they need to be deactivated after they exert their effect to be excreted. And this deactivation is carried mainly by an enzyme called TPMT. And for those who lack this enzyme because of a genetic variant in this specific gene, they will have no deactivation mechanism of these toxic, cytotoxic medications, which leads to a high risk of hematological toxicity. That was among one of the reasons of death among in acute leukemia pediatric children that reaches up to 2% of all these leukemic patients who are dying not because of the disease, but dying because of the toxicity of the chemotherapy. So this is another scenario showing us how pharmacogenomics is really functioning and is really affecting medication. So you might by now ask, is there enough evidence collected in the literature for pharmacogenomics and for its application? And to answer this question, I would like give it at or provide evidence at three different aspects. The first aspect, the safety aspect. So in 2023, one of the largest studies proved the very positive impact of pharmacogenomic testing on increasing the safety of medication. It showed that at more than almost 7,000 patients, when they were tested for pharmacogenomic variants before getting their medications, compared to getting the medications without pharmacogenetic testing, the arm of the treatment of the trial who had the pharmacogenetic testing had reduced risk of experiencing adverse drug reactions by 33%. So from another aspect, the evidence of efficacy, how pharmacogenomic testing can increase the efficacy of treatment, comes from a very old study that was published in 2010, when tacrolimus was found, which is an immunosuppressant, and it's given for patients after transplant to prevent transplant rejection. And it was found that those who were treated after pharmacogenetic testing with the correct dose reached the correct dose much faster than those who were not tested for pharmacogenetic variants. And only one enzyme that is mainly acting in activating and deactivating tacrolimus. So more patients achieved the therapeutic levels after 6 oral doses in the arm who were tested for pharmacogenetic variants in only this gene, and fewer doses modifications were needed until they reached the effective dose. So the third aspect that I will provide evidence in, that pharmacogenomics not only prevent toxicity, not only increase efficacy, it's also cost effective. It reduces the cost of healthcare. And this evidence comes from 2016 paper by Brixner and colleagues who tested only a couple of genes and who are active in the cytochrome P450 genes. So these are enzymes responsible for metabolizing medications. And these tests were applied for elderly patients who are taking polypharmacy, multiple medications, 5+ medications per day. And these were matched with 820 patients who were not tested for pharmacogenomic testing and were matching the previous group in age and the amount of medications. And it was found that testing alone the pharmacogenes, this was associated with a saving of $218. So we answered by this, or we provided evidence, and the evidence has been there for a long time, as you can see, for the efficacy of pharmacogenomics, or the positive impact in increasing drug efficacy and reducing its toxicity and in improving even the cost effectiveness of healthcare. So given this, we now, you might ask, but how much these are actual problems in healthcare? So in 2022, adverse drug reactions was estimated to be the 4th to 6th most common cause of death worldwide. Also, variable drug response has been always reported in the literature. It is known that about for only 50 to 75% of the medications that are typically used medications are effective actually on diseases. So we are still facing the same problems, and we are still suffering. The healthcare system is still suffering from the same problems, and we have some solution that can reduce the burden of these problems. So the question now, before I ask the question, another aspect that we have to consider, especially in our regions, that the clinical trials, most of the clinical trials that lead to medications that we already use every day on daily basis, and are conducted in Europe and the United States. So this map shows how many clinical trials have been conducted in each country or each area or region, and divided by the red are the most commonly the most common clinical trials have been conducted in these areas, while the yellow ones are in the middle, and the green ones, these are the least number of clinical trials have been conducted in these populations, although, as you can see, these are they are inhibited by a high population out of the worldwide population. So pharmacogenomics can help optimize the medications for those populations who were not considered during the clinical trials for developing the medications. So it is not only about the right drug, the right time, and the right patients, regardless of the patient's background. We can get closer to the patient when we consider his genes in our calculations for dose, in our selection between alternatives. So we are becoming more treating a patient rather than treating the disease. So after all of this, it's a very legitimate question to ask, what is the current status of adoption and why we are lagging behind in this? So this is, I will use the words that have been mentioned by experts from the field who are in the most advanced countries in the field of pharmacogenomics. So here is Dr. John Dacremont from the University of Manchester. So he is saying that it has been known since 1993 that as many as 1 in 500 people carry mutations in their mitochondrial DNA, which predisposes them to permanent hearing loss if they took aminoglycosides, like gentamicin. Surprisingly, despite these findings have been known for about 30 years, they are not a routine part of newborn testing for most children. And Dr. McDermott adds, in some clinical settings, we do the test. For example, when a child is diagnosed with cystic fibrosis, so they expect that he will get, for sure, need for multiple hospitalizations and need of aminoglycoside treatment. But the challenge is that most prescriptions of antibiotics don't work like that. You don't know years in advance if they are going to need the antibiotics. So if we have this information in the records of this patient, that this patient should not take aminoglycoside, because we have done just a very simple test when they were newborn, and then we will prevent hearing loss, a major disability that will affect that individual for the rest of their lives. And this is one of the benefits of the pharmacogenetic test that we still cannot reach to. Maybe you think that the situation in the States is better. So as United States is known as leading the research in pharmacogenomics, but actually this paper that was published just in October 2025 showed that pharmacogenomic uptake remains extremely low. Only 6.6% of the adults who, despite the strong evidence, and have been actually received pharmacogenetic testing, and despite the reimbursement and the national precision medicine initiatives that have been carried for many years now in the States. And the same study showed that demand is weak. Nearly 2/3 of the untested adults don't want to this test because they can't understand its benefit, which reveals a major awareness and education gap. Clinical integration is incomplete because less than 50% of the patients who received the test understood the results, and only 1 in 5 have received actual change to their medication according to their results. So the situation, even in the most advanced countries in the field of pharmacogenomics, are still very disappointing. So we might need to dig deeper into the reasons of this lagging in implementation. Again, I'll go back to those experts coming from their field. So here's Dr. Kelly Caudill, who is the director of the Clinical Pharmacogenomics Implementation Consortium, one of the most prestigious entities for producing guidelines in pharmacogenomics and enhancing the implementation of pharmacogenomics. She's saying that I think that not only is testing more available, but physicians are specifically looking at pharmacogenomics now to help their patients. Here in the USA, more insurance companies also are providing some reimbursement for these tests. However, she acknowledges that there is a main barrier. I still think we have got a lot of work to do on really educating physicians, not only on the benefit of ordering pharmacogenomic tests, but also on how to utilize it. I think there is still a big gap. And this part of her speech was announced in 2025. So we're still there. The next testimony is from a professor from University of Minnesota, Professor Jacobson, who is mentioning that many people who are healthcare professionals haven't been educated in the field. And she's saying that we have done a tremendous job educating our students. She's, of course, talking about the case of education of pharmacogenomics in USA, which is not comparable to that current status of education and other of pharmacogenomic education in other pharmacy colleges or even medical colleges around the world. But even though she thinks that many young healthcare professionals in the States have already been educated in the field of pharmacogenomics, but the reality is that the people in practice are still the older individuals, the more experienced and seasoned practitioners. They didn't get this when they were in school. So this is the case in the United States, and I think it will keep for a long time, even in our countries and other parts of the world, where still the education in pharmacogenomics is still lagging, even in the universities and educational institutes. So from another perspective, also from the UK this time, Ms. Kesselman, who works as a genetic counselor, thinks that cost, of course, is a big factor, both in terms of test price and whether the insurance companies or governmental health system in countries like the UK, where she is working, will pay for the test. So I think if this is a problem in the UK, it will be more like bigger problem in other countries, and especially in developing countries. I think our private insurers don't exactly see the value quite yet of pharmacogenomics. And that tends to be the sticking point as far as being able to connect our patients to this resource is concerned. So in her opinion, and it is a very valuable point, is the cost and convincing the insurers that whatever you pay for that pharmacogenetic test will reduce the healthcare cost, will reduce the hospitalizations, will reduce the unneeded medication given without any benefit. So we are at this point where multiple barriers are there and are like preventing us from reaching the potential of pharmacogenetic testing and its application. In this review, that was conducted in Qatar, which is a highly developing, fast developing country, and it has been there have been multiple genomic like initiatives in this country. So they have mentioned the main challenges in the researchers' point of view is that expenses of genetic testing and expenses of implementation and the pharmacogenetic testing complexity in some cases, the limited research on diverse populations, which is a very valued challenge in people from underrepresented population and in countries that are trying to enhance their research capabilities, lack of standard test and knowledge gap among healthcare practitioners. And they have suggested these solutions by increasing the awareness, by implementation of standardized guidelines, including diverse population in pharmacogenomic research, including of pharmacogenomics in curriculum and research, and insurance provision for genetic testing. So here we can see, like, for each challenge, there are multiple solutions. Still, we are talking about a country that is not suffering from financial constraints as many part of the world currently is suffering. So I think I missed one more slide. So anyway,
Okay.
in another slide, because I got this very nice figure, actually, that is a study from Iran, where the challenges in very low-income countries, they form like a network that is really very hard to solve. But for myself, I think the beginning always is from education and from increasing awareness. And also, of course, the next step should be starting with us as young practitioners, as researchers, that we have to put our finger on or point to each challenge and try to find our role in creating solution in this challenge. So this is from my end. I hope I have clarified how is the current situation in pharmacogenomics, and that's it. Please, I'm happy to listen to your question and answer them.
Thank you so much. It was amazing presentation, and I really like it. How was the challenges? There are different challenges of pharmacogenomic testing, but ultimately it is going to reduce the cost of the patient at the end, as like increasing the quality of life of the patient, decreases the hospital stay by reducing the adverse drug reaction or any adverse events by just testing. Can do a lot of things, but still there
Yeah.
are certain challenges are there. Help all the researchers, all the professionals, as well as all the viewers, that this video can help by implementing pharmacogenomics could save a lot of cost to the patient as well. And
Yeah, exactly.
basically,
So
yes.
yeah, from
So
my personal point of view, I think education and awareness is the key to change the current situation.
yes, yes, and this could be, very much helpful in cancerous patients as well. As I have seen that pharmacogenomics could be one of the best possible way to treat the patient to, different types of cancers patients. So this could
Exactly.
be, very much beneficial to them.
Yeah, so
So
maybe I can add here that pharmacogenomic is very important and very beneficial for cancer patients due to the high toxicity of chemotherapy and the high toxicity of cancer drugs.
yes, yes, exactly. Thank you so much for your amazing presentation. And I hope you all will like this video, and you can suggest your feedback or your comment in the comment section of this video. And see you next time. Thank you.
Thank you.
Thank you.